volunteer list.
Good point.
I like the seating, you look good. So you get the truth out.
Got it. I got it.
It's on.
Pam,
No, I think I'm still.
Joan, I got it. Oh.
It's low. It's
Okay, there we go. Got it.
Who's like a seat test?
So I'll start. I have the last, the third to last bullet that I saw, David, was a bullet on the cuts to graduate medical education. So in your opinion, I mean, that's always on the table. It's a tremendous amount that Medicare pays out to graduate medical education. However, we have a problem because we really do need to train primary care physicians, and cuts to graduate medical education seems counterintuitive a bit. So in your opinion, or perhaps it would be Tim would want to weigh in on this, will this be something, if it does come to fruition, is this going to be a surgical cut, so cuts to, you know, subspecialty training, or how do you think that might play out?
I don't know if this is on.
Oh, there's the button.
Oh, thank you. There will be no cuts to graduate medical education because I'm not allowed to let them happen. No, seriously, this would be a huge concern if they ever really did reach a big deficit reduction agreement. And unfortunately, if you look at the Simpson-Bowles plan, you look at all of the different deficit reduction plans that have been put out there, almost all of them have on the list cutting teaching hospitals and the Medicare payments they get for graduate medical education. What we have said in response is some of which you just said, which was we obviously need more, not even just primary care physicians, but in the future, given the graying of the population, given the ACA coverage expansions going into effect, and clearly there's going to be increased demand for healthcare services over time because of the ACA, the last thing we should be doing is cutting back on Medicare's support for teaching hospitals and for graduate medical education programs. Most of the cuts proposed that we've seen have just been sort of a slashing in the payment rate add-on that teaching hospitals get to help cover what are known as the indirect costs of medical education. The fact that teaching hospitals tend to have more complicated cases than non-teaching hospitals. The fact that there are some inefficiencies associated, obviously, with training physicians, because you have a lot of physicians in training ordering tests and doing the other things that they do. And so some have argued that that payment add-on is too high, and so therefore they argue it should be cut back. What they don't mention is that the Medicare payments for direct graduate medical education, which are the resident salaries, supervising physician salaries, and other direct costs, are grossly underpaid. But they don't look at that. They just want to look at the one silo where they say you're overpaid. So hopefully we can keep it from happening, and I think there's more understanding in Washington about the fact that we don't have enough physicians, as well as other allied healthcare professionals, and so hopefully that will help rule the day. But when they get to the point where they're going to cut $400 billion out of Medicare over the next 10 years, nothing's really safe.
Do we have any? Yes.
I don't know who this is addressed to, but can you address what effect the state's Medicaid redesign team proposals and their implementation is going to have on Medicare spending in New York, and potentially the forcing of Medicaid recipients into managed care? What effect that'll have on medical costs and in the New York State budget?
Okay, well, the Medicaid redesign team reforms, started a couple of years ago. They're ongoing. The basic concept behind all of the most of the reforms is care management for all. So all Medicaid beneficiaries are supposed to enroll in either a managed care plan or some other form of care management. Most Medicaid recipients in the state are already enrolled in managed care plans. Right now, what they're doing is bringing in some of the more complex cases that have been excluded, and they'll be bringing in nursing home patients, they'll be bringing in individuals with serious mental illness. So that is all new, but it's not a new concept to enroll them in managed care. This is just sort of more intensified in trying to get at the high-cost patients, get them into care management. The other part of the MRT reforms that are really being effective in terms of keeping Medicaid costs down in the state is the global cap. There is a cap on Medicaid expenditures. They're only allowed to grow by basically a CPI type factor, about 4% a year. And most of that in the past year and a half has been taken up by Medicaid enrollment. So that's really left no room for any, hospitals haven't had a Medicaid rate increase now in 6 years, I think, something like that. So the impact of that is actually that most hospitals are shifting costs to private payers, and I'm sure you will attest to that, because Medicaid rates aren't covering costs anymore. So that's just a fact that it probably will happen increasingly in the future, not just on the Medicaid side, but on the Medicare side, as Medicare payment rates increasingly don't cover the cost of providing care to Medicare patients.
Another question?
I have a question. I'm Steve Wasovich, one of probably the young blood physicians to join the workforce. I really appreciate everything everybody said. I think it's extremely terrifying for a new physician, and I actually come from a business policy background, so for me, I can sort of digest this a little bit easier. But it's extremely scary for somebody that for instance, graduated from a class of 116 medical students just recently, 3 years ago. I'm the only one to pursue a career in geriatrics. If you look at the 5% of the population, they incur 50% of the cost of the geriatric population. And if you look at where the healthcare system is heading, everybody's saying more. Everything should move towards home care. Patients have medical homes and primary care. But there just aren't enough people, medical students, going into these fields. It's hard enough to survive today, and with all these penalties, like Mike mentioned, why would I want to even deal with that? Where some bizarre lawsuit or some brand new college student that they hired from Chuck E. Cheese that goes into work for IRS can now take away my career and everything I've ever worked for, the $200,000 in loans that I've acquired. Is there anything that, is anybody saying anything about what is there to encourage physicians to go into primary care to support them? It sounds like physicians are becoming more of a commodity than anything else.
A couple of things. First, I would just say part of the concept behind the patient-centered medical home is to create a different environment for primary care physicians to work in that might be more attractive to them. I mean, there's been a lot of discussion about the hidden curriculum when you're a medical student and you're a resident, discouraging people from going into primary care. And I think part of the thinking behind creating this new practice environment was to, frankly, make it more civilized and reasonable and make those who might be interested in it more interested and want to do that. I think there's also issues around payment, though, and physician reimbursement. I think that the patient-centered medical home can only go so far, but there are provisions to address the physician payment issue to try to equalize it a little bit in the Affordable Care Act, and I think the plans are also doing more in that area. So, but at a certain point, I mean, it'll be interesting to see how this all plays out. I mean, I think Pam or somebody had mentioned the whole issue of, it might have been Jay, the scope of practice issues. I mean, the scope of practice issues are very interesting. I mean, I was part of the Medicaid Redesign team work group on workforce, and there is a feeling out there among some that maybe primary care can be broadened a little bit to have others, nurse practitioners and others, do a little bit more, and it doesn't really have to only be physicians. I think there's a little experimentation that we need to do to see what exactly works the best. But
yeah, one of the things that is I did learn, and I didn't talk about it, is that less and less physicians are self-employed now, and ACA didn't start this trend, but it's certainly not doing anything to stop it. So, that's, and you talk about costs, and that was always the assumption. You go to medical school, you start a practice. Well, you don't have to now, and I don't know, I'm not gonna say that's good or bad, but, there's other options out there, other opportunities, and sometimes, and as some of the care patterns change, hopefully there'll be less need for specialists in the future, so that and more need for the kind of thing you're doing. And I think, it's not, you can kind of see the future, but you can't see how you get there, I guess, or at least right now, at least I can't see it. But I'll let anyone else.
I would just add that there's also a provision in the ACA that's already been put into effect, which requires states through their Medicaid programs to increase primary care physician reimbursement to 100% of Medicare. And as you probably know, many states' physician reimbursement is really, really poor. So it only goes for 2 years, and so who knows what's going to happen after that, but it's fully funded by the federal government for 2 years.
The other piece of the reimbursement that I saw go up is there's a 10% primary care bonus provided right now by Medicare. I think if you exceed 60% of primary care patients, you get 10% per quarter. I believe that's it, but I'm not sure. I'm engaged right now in looking at a frail elderly medical home project. It's a small project, and one of the things that I think is really important, and actually goes back to what some of the other panelists were saying, is the importance of really understanding the patient and getting the data that you need to really document how you take care of the patient. So when we started this project, we were going through records, and we're trying to document everything using the system that Medicare uses to capitate risks, so the HEC system. And we were grouping them, and we noticed that as patients were traveling through our system, sometimes they had chronic congestive heart failure and sometimes they didn't. Sometimes they had diabetes and sometimes they didn't. Well, that wasn't true, but it was true of the documentation. So I think this thing about getting a grip on the data and then using the data both to your benefit but also to the patient's benefit is very important, because I can't imagine that a patient that arrives in our emergency room and has diabetic retinopathy and it's not documented on his chart is going to get the right treatment. So I think there are things that primary care physicians can do, especially in this medical home environment, that can be really productive and really high quality and change the way that care is delivered. And I mean, of all the things, I think that's the most optimistic piece.
I have multiple comments to make. One is, I do agree with any position over there. Within the next few years, probably there will not be solo practitioners, not a small group practices, because I think the way the healthcare industry is moving towards the ACOs, the integrated delivery systems, or patient-centered medical homes, all of this is happening. On the contrary to it, on one side, Medicaid and with the primary care rate increases, that's actually kicked in as of April 1st, 2013, going up to 2 years, matching it to the Medicare funds. They are, in fact, actually encouraging the medical students to go into primary care instead of actually getting absorbed by these large institutions to set up their practices, indicating that there is a future in primary care. On top of it, to let the young physician know, yes, as Pam said, there is an incentive program for the primary care. Incentive program is also there in addition to the primary care rate increase. It all depends on how actually you utilize the data and how you actually manage the data and how you report the data is one thing. And the second thing I want to make is, you talked about all these things coming into the industry, and on one side you have the False Claim Act, fraud and abuse, and there is no curriculum in the medical students program talking about it. Data is very important. But when the students are not being taught how to document it, and it's very difficult when they become the physicians probably, yes ma'am, you're right, the patient comes into emergency room for probably a hearing, has diabetes, but in fact the physician really didn't manage diabetes. How do you address that patient? It's a chronic condition. And that should it be documented? Shouldn't be documented? Yes, they document it from a medical history perspective. However, are you using that diagnosis to indicate it on the claims data where you're going to use the data? So there are multiple things in healthcare, starting from the medical student level all the way to the physicians and to the administrators and to the hospitals, that we feel that there's a wide gap. And who is going to bridge that gap? Federal government is coming with a lot of regulations. The state government is coming with a lot of regulations. Payers are coming with a lot of regulations. Various providers, whether it's the physicians or the hospitals, where do we stand in absorbing all that information and balancing our financial needs to the clinical regulations? We feel there's a big gap, and we want people like you to come and bridge the gap between all the triangle, the payers, the providers, as well as the administrators in the industry. And I have another question for on the PCRIs from Medicare rate increases. Medicaid is doing it in terms of matching it up to the Medicare funds. And it's actually not just under the health payer industry as such. For the primary care services, are they going to match it to the same Medicare levels? Because the reimbursement rates for these evaluation management services in the primary care rate, evaluation management services are not in par, not part of the Medicare rates. Is there a mandate by federal government or by the state that even the private insurance companies will actually match their reimbursement to at least Medicare? Right now most of the rates are like 80% of RBRBS or 90% of RBRBS or 70% of RBRBS. Why should it be only for Medicaid that we should be able to match the 100% of Medicare? Why don't they mandate it for non-Medicaid private insurance patients where we get the 100%?
Well,
Because Medicare is cutting the cost on the 2% sequestration.
Well, the answer is I don't know. I'm guessing that if Medicare did what you want them to do, they'd have to pay. They still have to pay for it somehow, and money comes either directly from Medicare to the provider or from Medicare to the health plan to the provider. So there's no free lunch in this stuff. So.
Especially at least on the Medicare managed cares and the Medicaid managed cares.
I honestly don't know anything about our reimbursement policies.
Actually, on
Managed cares, yes.
Medicaid managed care, they're required to pay the 100% too.
So I have a question, and I think, oh, there is a question now.
I have a question, I don't know how relevant is that question, but besides 2014 ACA is going to have great impacts on all the practice, what about the migration from ICD-9 to ICD-10? What is your assessment in terms of the added impact on practice on top of this ACA? And do you have any good suggestion or solution for practice?
No, but that's what Michael talked about. There's going to be so much more data available to everybody. I know it's complicated. They pushed it back a year because it was too much to do with all the reform. But that's the kind of data that Michael was talking about, that people are going to need, be able to use. It's going to help. That's the whole purpose of this, essentially, to improve quality ultimately.
I've done some analyses on ICD 9 to 10, and I think it's really, really important to, certainly from the hospital perspective, and I think the physician offices, they have CPT codes, so that's good, because there's not as much conversion, but you need to understand and negotiate with your insurance companies the translation of the ICD-9s to 10s, because they're not one-to-one matched, they're one-to-many matched, there are explosions, it's very, very complicated. You need to, this is something that is well worth investing in somebody who really understands the business to talk to you about it and be able to really look at where you are now and where you're going and do it before you're being paid that way. Because there are issues to address in the negotiation. So having said that, if you can make that leap, the benefit is that you have terrifically much more detailed data.
14,000 ICD-9s are actually translating into 70,000 ICD-10s.
Yes.
It's a big impact in that sense.
Did I see another hand?
Just one quick thing is I think what I heard today is it sounds next several years or next decade is very discouraging for physicians that are near retirement age or close to it. It's not a friendly environment when you have, it's busy, it's hard enough to take care of a patient with multi-organ failures, and you have to comply with all these regulations that are enormous. And you keep throwing in more and more regulations. I know data is helpful to a lot of people, but imagine taking care of sick people and you have to be responsible for so many things, and anything you do wrong, you can be held liable or accountable or penalties. I mean, who wants to practice like this? When you're financially kind of secured, I think it's just getting impossible to stay in practice. I see a lot of doctors are going into these options of selling their practice to the hospitals. But I see a big difference between providing care to a patient when it's your business and where somebody else's business and you're just an employee. I think productivity is going to be hugely compromised. People are going to be less accommodating to their patients, and they're going to be, I'm going to only going to see so many patients a day, and they call it a day.
I heard somebody talk about physicians selling their practices to hospitals, and they said that, in the year that they looked at it, the first thing that the physicians did once they became employed by the hospitals was to go on vacation.
I mean, you do so many things for free as a physician. You answer calls at night. You can't charge them. You have to authorize his home care, and you don't bill for it. And I just heard from Medicaid, this auditor saying, giving us a lecture, and saying that if you authorized it and it was deemed medically unnecessary, they can try and retrieve the money from the agency, but if they're not successful, they can hold you responsible and go after you. Well, I never made a dime from those things. I mean, what is medically necessary? What is that? I mean, 10 years ago, nobody had home care. I mean, people didn't die left and right. Those are not medical stuff. Those are people who are just taking care of them, doing grocery. Those are families' work in the past. So why are they putting so much pressure and burden on physicians when we have so much work to do just to take care of the sick? I mean, it's not even our duty.
I think the fraud and abuse piece is particularly daunting, and it's daunting for physicians, very daunting for hospitals, very daunting for nursing homes. It's all over the place. It's amazing to me. I don't think it's quite rational at this point. I think that the government is being much more aggressive than I would have thought they would have been if they really wanted to create transparency, which is what the title of the legislation says. I have to agree that I think they should really rethink it, how their approach to this.
The AMA letter newspaper showed that 50% of the cardiologists and physicians are burned out, not because of the work, because of the regulations and the fear of something. Oh, if I build something wrong, they're going to hold me up. It's too much to worry about.
I don't disagree with anything you said. I just think one of the things you can think about is what many of your colleagues are doing is coming together with other physicians who think like you, practice like you, or maybe in the same position, because then you can consolidate resources, you can cut costs, you can share capitalization, you can then fight back in a better way. You can hire, as was said before, a consultant to work on the transition, ICD-10, things like that. That's why you're seeing these larger groups being formed, and that's why you're seeing the market change. You're right, the solo two-physician practice is virtually unsustainable at this point. But I will tell you, my cynical answer to your question is it's a lot easier to control 10 groups than it is to control 1,000 practices. It's a simple answer. That's why it's being done. If there's less hospitals, it's easier for them to manage. If there's less medical practices, it's easier for them to control. So as you come together, you hopefully come together to fight back or to regain power. But I don't question, I think you're absolutely right that it is unsustainable. So I'd encourage you to talk with your colleagues, people that you work with, or similar specialties, the same to the young physician. The last thing I would say, just to circle back on your question, and one thing that you all have that you don't use well enough are your patients. I will tell you, if I had a geriatric practice, oh boy, you can get a couple of thousand angry senior citizens, trust me, they're going to listen to them. All right, so think about using your patients more to drive change. They're not going to listen to lawyers. With all due respect, they're not going to listen to all organized medicine and everyone else. They're going to listen to your patients. They don't care what doctors, lawyers, consultants, and other people say. Use your patients to drive changes. They will happen. If you're not getting paid enough to take care of them, and they push for it, you'll get it.
So one more question. I think we have time for one more question, right?
I'd just like to ask the panel, if you have a crystal ball looking 5 years out, and you have a 900-page document which is being revised, it sounds like monthly, okay? Do you think in 5 years this act will exist, or will we just transition to a Medicare type of single-payer system? Instead of having all these, ACOs, patient-based medical home, Medicare is deemed to be the most efficient payer in the country, am I correct? Their fee to pay is 86 cents a claim. Okay, they've already negotiated fees with most of the physicians in the country. Why are we going through this when we can just flip the switch and say, okay, everybody's got Medicare?
I have the microphone, so I'll go first. I think not only is it the 900 pages, but it's the easily 9,000 plus pages of regulations that have been written along this. So it's doing stuff that ACO is doing that hasn't been done before in a lot of ways. So it'll be here, and it'll be here in a bigger way. I don't think we have enough time for me to argue your points about Medicare's efficiency, but I think just the short answer is that yes, it'll be here.
Yeah, I think it will also, and I think, in terms of replacing it with something else, I think the odds of that in the short term are very, very low. Just think how difficult this whole process of getting this passed was. I don't think too many politicians are going to be willing to undertake a major overhaul or implementation of a new program anytime soon.
Just one quick comment. I think one of the things that you really heard tonight in all these wonderful presentations, leave myself out, is just the ACA is not one thing. So I wouldn't say that there's an it there. There's a whole lot of different pieces. And I think part of what you heard was there's the insurance expansion, there's Medicaid, there's the private market. And a lot of what Pam and I talked about is really experimentation around the delivery system. Accountable care organizations, patient-centered medical homes. The Innovation Center at CMS is so active right now, testing so many different things, and they want to find out what is going to stick. So 5 years from now, 10 years from now, you'll see the proof of what stuck during this time period and where the evidence really came out for what was really successful in preserving quality, improving quality, bringing down costs.
The question of moving to Medicare for all, as it is, There are so many people in Washington who say Obamacare was socialist, let alone moving to a public payer, single payer system. It just wasn't going to happen. I mean, they tried to have what they called the public option, you know, through health reform, and that couldn't even make it through. So unless you had a real huge cataclysmic event that tanked all the private insurance companies, sorry Jay, in the country, so that there was no choice but to move to something else, it's really unlikely that that'll happen.
My only comment would be that it has to be more change to come, clearly, but also with the number that kept, I think almost every one of the speakers commented on, that there's a 2.6 million was the intended goal to cover, and only 1 million are being covered. So we still have, if you look at the original foundation, this entire effort was to cover the uninsured, we still have the majority of that not. So the foundational goal of all of this incredible effort hasn't even been achieved, not even to a large number. I mean, 1 million, no question, is a large number of covered lives, but it still has 1.6 done. So to the point for the hospital association, the hospitals of the state, they're still looking at the same dilemma. Hopefully there will be solutions, but I think there has to be something else yet to come.
And I think we're going to draw this presentation, this whole seminar to a close. And I have one word to say. It's just wow. I think that the panelists were incredible. The topics were very, very difficult to cover in such a compact amount of time, but you all did such an incredible job of really hitting the important points and raising everybody's understanding, I think. And the audience was terrific. Thank you for the questions. I think that they were, the questions and the comments were intriguing and interesting, and this discussion was just fantastic. Thank you, Stony Brook, for sponsoring this and all of the help we had from the development office in getting this off the ground. And I think that's it.